Good afternoon, everyone. We might get this webinar kicked off. So welcome. My name is Elise Hall and I'm the Director of the Research and International Policy section within the Department of Health and Aged Care. I'd like to welcome you all this afternoon for this week's instalment of the NDARC webinar. Before I start, I would just like to acknowledge the traditional owners of the lands throughout Australia and recognise their continued connection to land, waters and culture. We pay our respects to elders past, present and emerging. Today's talk is on the current trends in overdose and other drug-induced deaths in Australia, release of the 2023 report. The National Drug and Alcohol Research Centre has reported on overdose deaths in Australia via an annual national report for over 2 decades through Drug Trends, which is an Australian national illicit drug monitoring system funded by the Australian Government Department of Health and Aged Care. This webinar will discuss findings on trends in overdose and other drug trend deaths in Australia, including the 2023 report, which has been released today. I would just like to advise that this webinar does discuss issues related to suicide, overdose and drug dependence. And I'd like to remind you that if you or someone you care about is affected by the topics raised in this presentation, then please seek support from contacting Lifeline or through the National Alcohol and Other Drugs Hotline, whose details we've shared in the chat. Today, we are very lucky that we will be having a presentation from Amy Peacock. Amy is an Associate Professor and Acting Deputy Director of the National Drug and Alcohol Research Centre at the University of New South Wales. She is also a National Health and Medical Research Council Emerging Leadership Fellow and the Program Lead for Drug Trends. We're also very lucky to have some very experienced and knowledgeable guest panellists join us today to offer their thoughts and to answer any questions. The guest panellists today include Lauren Moran, Director of the Mortality Data Centre, Health and Vital Statistics Section at the Australian Bureau of Statistics. Melanie Walker, Chief Executive Officer of the Australian Alcohol and Other Drugs Council, and Paul Dessau, Chief Executive Officer of Peer-Based Harm Reduction Western Australia. We're going to have some time at the end for questions, so please do send them through. If you want to ask questions, then please do so through the Q&A function. Please do not use chat, and I will present them to the panel at the end of the presentation. I may not be able to ask them all, but I will try to do so, so please be patient. Okay, without further ado, I'll now invite Amy Peacock to present on today's findings.
Thanks, Elise. Thank you so much for the introduction, and thanks to our panelists and to all of you for joining us for this webinar today. We're really pleased to be able to share the results of all this hard work behind the annual report with you all. To start off with, I'd like to acknowledge the traditional custodians of land throughout the country we now know as Australia. I want to pay my respects to their elders past and present and extend that same respect to all Aboriginal and Torres Strait Islander people here today. I'd also like to honour and pay my respects to the people behind the numbers that I'm going to be presenting today. Many of us, myself included, know one or more people who figure in these statistics, be they family, friends or acquaintances. And while I'm going to talk a lot of jargon, a lot of rates and trends, I just want to remember and remind everyone about the individuals behind each number, often who have family and friends and many others left behind who remember them. As mentioned, we have posted the helpline numbers in the chat if this does raise anything for you and you'd like to speak with someone further. And please know that we think of these people, and this is the reason why we do this work, to acknowledge the experiences of their people and try and prevent such deaths occurring in the future. So I think that message in and of itself provides the rationale as to why we study trends in overdose and other drug-induced deaths. And I'm sure everyone attending this webinar already has a really strong understanding of why it is so important to study these deaths, particularly given the stigma that continues to persist around overdose deaths. But I just want to do a quick recap, because really at the crux of it, we know that overdose and other drug-induced deaths are a leading cause of premature loss of life in Australia and internationally. and that many of these deaths can be prevented. There are strategies that can reduce the risk of a fatal overdose, so things like giving out take-home naloxone. There are strategies that can reduce the risk of experiencing overdose, so things like opioid agonist therapy. And then there are strategies that can help to reduce the vulnerability to experiencing such harms in the first place, such as our broader public health and harm reduction approaches to drug use. By characterising these deaths and understanding changes in the characteristics underpinning these deaths over time, we can identify potential points for intervention to prevent future deaths. This includes understanding factors at the level of the substance that consumed, so which drugs are consumed, how they might interact together and how they were consumed. We can understand factors at the level of the individual. We can look at their history of substance use, their tolerance to their drug, and their broader physical and mental health as well. We can understand characteristics of the setting. Were there witnesses present? Were there overdose signs, ability to administer naloxone, and barriers to seeking professional help? And then we can also understand these deaths at the broader societal and environmental level. We can look at the availability of treatment for drug dependence through care between prison and community life, and experiences, as I mentioned, of stigma, discrimination, and deprivation. So the fact that the experiences of those who have passed can tell us so much about how to reduce the risk for those living, I think creates a responsibility to regularly study these data and use them as a key source to inform policy and practice moving forward. So, how do we understand drug-induced deaths in Australia, and what data do we have? As a really brief summary, deaths in Australia are reported to the state and territory registries of births, deaths, and marriages. Some deaths are referred to the coroner for investigation as to the cause of death, and more in-depth reporting around, more in-depth reporting on those reports. And this can include things like autopsy reports, toxicology testing, and police reports. And all of this information is stored in a database called the National Coronial Information System. And we know that around 97% of drug-induced deaths do get referred to the coroner and do go through this process. So these two sources of information, the State and Territory Registry of Birth, Deaths and Marriages, and the information from the National Coronial System, are passed to the Australian Bureau of Statistics, who process these data and create a single data set called the Cause of Death Unit Record File, which contains information on cause of death for all deaths in Australia. What ABS does is they apply a classification system called the International Classification of Diseases, or ICD, and they use this to identify a single underlying cause of death, and that is the disease or injury that initiated the train of events leading directly to the event. So that's the underlying cause. But they will also identify associated causes of deaths. And this may include diseases, injuries, and other health-related factors that contributed to death. Information from the registries is available relatively quickly, but for those deaths that go to the coroner and go through the National Coronial Information System, they can take some time to be closed. And while they're being investigated, they may not be able to be reported on or reported on in depth. So for this reason, ABS undertakes a two-stage process of revising mortality data over 3 years as more coronial information becomes available. So in the report that we're talking about today, using ABS data, the most recent year of data is 2021, and that data is preliminary. It has undergone one round of revision, but it's considered preliminary. The second round of revision, which in this current data is 2020, is called revised, and then data in the final stage are considered final. And that in this report comprises data from 2002 to 2019. So what do we do at ENDA? As Elise mentioned, we have a program of work called Drug Trends, which is a national illicit drug monitoring project funded by the Australian Government Department of Health and Aged Care, which has been running for over 2 decades. Our job, we collect, synthesize, and report on lots of different data sources on illicit drug use, markets, and outcomes in Australia. And as mentioned, we've been issuing a report on drug-induced deaths for over 2 decades now. So what we do, we obtain from the ABS very kindly the cause of death unit record file at the level of each individual death each year. And we use this to generate the report, which has been released today. We also use these data in a number of other ways, including publishing it alongside other data sources, so things like hospitalizations, treatment episodes, survey data, to get an understanding of what's happening with drugs in Australia. Now, I'm not going to be presenting on data from the National Coronial Information System today, but I do want to flag that we do have access to the National Coronial Information System database itself as part of Drug Trends, and this allows us to publish really in-depth information around deaths in quite a timely fashion. And this piece of work is led by Professor Shane Dark. So you can see here some examples of recent work that's been published using the National Coronial Information System. When we talk about drug-induced deaths, there are different ways of defining it. And so I wanted to give a really clear idea of how we define overdose and other drug-induced deaths in this report. Thinking about the broader category, we talk about drug-induced deaths, and that is an instance where the single underlying cause of death has an ICD code that indicates either a substance use disorder or a code that is indicative of a direct harm of substance use, for example, poisoning or otherwise overdose. In our definition, we do exclude deaths that have arisen from accidents caused by being under the influence of drugs, such as motor vehicle accidents. That may be, for example, where someone has consumed a pharmaceutical opioid prior to the accident, just because of the difficulties around attribution. And we also exclude deaths that are directly attributed to alcohol and tobacco. And that is the reason for that being that reporting on those deaths are covered by other agencies. What we do include in drug-induced deaths, though, are deaths that are attributable to the use of illicit drugs, so drugs like heroin, deaths that are attributable to use of prescription medicines that may be prescribed to the individual or obtained via other means, and medicines that may be available over the counter. What is important to note that is out of this broad definition of drug-induced deaths, the majority of those that we are studying are actually drug poisoning or overdose deaths. So typically around 97% are what we would call overdose deaths. And this is where the death has been attributed to the acute toxic effects of a drug. In our definition, we include overdose deaths regardless of their intent, be they intentional, unintentional, or of undetermined intent. And finally, I just want to note that we work really closely in partnership with the Australian Bureau of Statistics and the Australian Institute of Health and Welfare on this reporting, and we're really delighted to have Lauren on the panel today because we work so closely with Lauren to ensure our reporting aligns across different agencies. So we make sure our definitions and our codes align, and we regularly work together to review our approaches across agencies and to check that it aligns with best practice internationally as well. So a final note, just before I get to the results, and that's because, as I mentioned before, ABS undertakes a revision process with these data over 3 years. What you can see pictured here on the side are the case closure statistics for deaths that are referred to the National Coronial Information System, that are referred to the coroner. So as you can see here, in 2021, it's around just over 1/3 of deaths that we're talking about have been, or 1/3 of deaths that are been referred to the coroner have been closed, and that is have had officially confirmed the cause of death. So what this does mean is that with the deaths that we're talking about for 2002 to 2019, those deaths have been through the revision process and they are considered finalised. Those estimates are not going to change any further. But for 2020, they have been through one round of revision, but they still have a subsequent round of revision to go. And based on historical changes through this revision process, we anticipate that the estimates for 2020 that we're presenting here may change by up to 1.6% when they are revised by ABS in a few months' time. Similarly, for the estimates for 2021, they still are yet to go through 2 more phases of revision. With the next phase of revision, we anticipate that based on historical information, they may increase by, say, up to 11%. And then in this next round of revision, again, up to around 1.6%. So I guess the take-home message from this slide, and before I kick off into these numbers, is that the numbers for 2020 and 2021 are subject to revision, and they will only increase upwards, particularly for 2021. So to move on what you're all here for, what is the trend that we're seeing in overdose and other drug-induced deaths? To start off with a picture for 2021, so what we saw in 2021, based on those preliminary estimates, is that there were 1,788 drug-induced deaths among Australians in 2021. And this is equivalent to 1% of all recorded and reported deaths in Australia. What this equates to is around 6.9 deaths per 100,000 Australians, or rather approximately 5 deaths per day. Australia has experienced a rise in the number of drug-induced deaths, and that number peaked in 2017 at 2,003 deaths. However, while it's important to study the numbers to acknowledge the impact that it has, we really need to look at rates adjusted for population size, because we know that there's variation in the size of the population when we're trying to understand trends over time. So for that reason, for the most part throughout this presentation, I'm going to focus on rate per 100,000 people. I'm not going to go too much into the details, but essentially we undertook a form of time series analysis called John point analyses for the period from 2002 to 2019, so the finalized data. What you can see, and I've got the trend line displayed there, is that the rate of drug-induced deaths increased by around an average of 3.5% per year for the period from 2002 to 2019, and they peaked in 2017 at 8.2 deaths per 100,000 people. As I mentioned, estimates for 2018 and 2019 are finalised, and they seem to sit somewhat stable relative to 2017. When we look at those estimates for 2020 and 2021 that are subject to revision in future, they do look to be decreasing downwards, and indeed we saw an 8.9% decrease from 2021 to 2020. But I just want to emphasize again that those numbers are subject to revision, the 2020 and 2021, and will only increase upwards. So I'd be very cautious about claiming a decrease in deaths at this point. In saying that, that dip from 2020 to 2019, I'm sure has raised questions for people listening, and a question that has been in our minds for a long time around what was going to happen with drug-induced deaths with the onset of the COVID-19 pandemic. We know that the pandemic had implications in terms of drug supply and demand, at least temporarily, and there were a lot of concerns about what this would mean for changes in drug-related harm, particularly with potential disruption to drug treatment and harm reduction services, which we did see temporarily. Sorry, going the wrong direction. But also thinking about the other consequences of the pandemic with social isolation, mental health problems, and other factors that we saw. And while I wish I could give you a really firm answer now, I think we're still really early on in trying to understand what's happened with overdose and other drug-induced deaths. Mostly for that reason, because it does take a while for the coroner certification of drug-induced deaths. So what we have done is a crude comparison of the quarters since the onset of the pandemic. So from quarter 2 2020 relative to 2019, to just try and get a crude understanding or early indicator of what's happening. And from what you can see here, we saw that there was a decline in the rate of drug-induced deaths in quarter 4 2020, quarter 2 2021, and quarter 3 2021 relative to the same period of 2019. I feel like I'm going to be making a lot of caveats throughout this talk, and I do want to make that again, that these really should only be taken as a tentative early indication, that it does not seem to suggest at this stage a dramatic increase in deaths. in drug-induced deaths with the pandemic, but there are many factors that may influence these estimates. And as mentioned, they will be subject to revision. We are undertaking more detailed temporal analyses that have just been complete, and we hope to have them published soon. And again, I do want to emphasize that there is some variation in this by jurisdiction as well. So we've talked a little bit about the trend overall, but I guess going back to that point around the characteristics underpinning these deaths and trying to understand a bit more about the people who are experiencing these deaths and how that profile, that socio-demographic profile may have changed over time. So in 2021, when we look at the breakdown by sex, we can see that drug-induced deaths were nearly twice as frequent among males as compared to females. And this has been relatively consistent over time in terms of the distribution by sex. When we undertook those time series analysis, looking at what was happening from 2002 to 2019, so that those years when we have finalized estimates, we can see that the population rates of drug-induced deaths among both males and females increased. So for females, it increased around 2.9% on average per year. And for males, it increased around 3.8% per year. Looking at those two most recent years, so 2020 and 21, where we have those preliminary or those estimates subject to revision, the rate for females stayed relatively stable, whereas for males, it did decline slightly. Again, potentially subject to revision. And I want to say that while our sex distribution has remained relatively stable in terms of death being more common among males, we need to really consider other demographic characteristics, because that picture of stability isn't necessarily true for other characteristics as well. So on that note, while the sex profile that we see in terms of the distribution among males and females has been relatively consistent, we have seen significant shifts by age over time. So in 2021, the highest percentage of drug-induced deaths was among those people aged 45 to 54, followed by the age group 35 to 44. And this is actually a change over time. So in the early 2000s, it was really kind of the young to middle-aged adults, that 25 to 34-year-old age group. So if you have a look on the slide, looking at that kind of purple line, they were the primary group who were experiencing drug-induced deaths in the early 2000s. Looking more recently, it's while it's fluctuated a little bit for that age group, it's remained relatively stable, or at least hasn't increased for them over time. By contrast, though, if you look at the older age groups, for the most part, most of the age groups from 35 up have shown an increase over time, and particularly for the 45 to 54 age group. So if you look at that blue line, they are now the most common age group represented in drug-induced deaths. In terms of looking across the two most recent years, there's only one age group that showed an increase between 2020 and 2021, and that's the 85 plus age group, which you can see there in that lighter green color. Now, this group there are smaller numbers underpinning this rate, and they have, as you can see, looking at that trend over time, it has fluctuated over time, but the fact that rate has increased from 2019 to 2020, and then in turn to 2021 is concerning, because we know that those numbers are potentially only going to increase any further. While it's not shown here, when we've drilled down into that data a little bit more for that 85 plus age group, we see that change, that increase is apparent for both males and females, and it really seems to be driven by deaths that are deemed to be intentional and involving opioids. And I want to ask you to keep that point in your mind, because I want to come back to it a bit later on. Moving to look by remoteness area, as you can see here in 2021, the majority of deaths occurred among people residing in major cities. And really that picture around the predominantly occurring in major cities, that's been pretty consistent over time. But again, coming back to that point around the importance of studying rates, we know that there's different total population sizes between major cities and regional and remote areas. And when you look at these rates, what that tells us is that we start to see more convergence between these different remoteness areas. So while looking at the most recent year, we see that major cities in the red there in the graph, they have the highest rate of drug-induced deaths. We can see that the regional and remote areas are starting to converge in the more recent years, although there is some fluctuation over time. And for the first time, so we haven't actually been able to report on this previously, but for the first time, we are able to report by socioeconomic area of residence as well. And to do that, we use a thing called the Index of Relative Socioeconomic Advantage and Disadvantage. And really what this number essentially tells us is about the economic and social conditions of people and households within an area. So when we look at the area within which people who have passed have lived, what we can do is assign this number that tells us about the level of advantage or disadvantage in that area. So looking at 2021, what we see is that 32%, so 1 in 3 drug-induced deaths occurred among residents of the most disadvantaged areas in Australia, and over half in the lower 2 quintiles. When we break this down by all the different characteristics which we have access to, we see that this trend holds pretty much consistent no matter which way you break it down. So it's the same, it's the same for both males and females, and that the greatest proportion of deaths for both males and females are from the most disadvantaged area. We see it by all age groups from 25 to 84. The exception would be the 15 to 24 age group, who are more likely to reside in more advantaged areas. We see it across both intentional and unintentional deaths, and we see it across all drug types except for drug overdose deaths involving cocaine. So while we do see drug-induced deaths across the full spectrum of areas in terms of disadvantaged to advantaged socioeconomic areas, I don't think it will come as a surprise to anyone that they dominate in the more disadvantaged areas. And again, that's a point I'd like to keep in mind for us to come back to. Moving on, I'd like to talk a little bit now about the circumstances of death driving these trends, because as we know, this is so important in terms of strategizing as to how we can intervene and try and prevent these deaths in future. As I mentioned earlier, when we're talking about drug-induced deaths as a whole, really we're talking predominantly about drug overdose deaths. 97% of drug-induced deaths that we're studying are overdose deaths. And when we're talking about intent, we're really focusing on overdose deaths because it is the overdose death specifically where an intent is assigned. So in 2021, it was 2/3, so around 2 in 3 of drug overdose deaths were coded as unintentional and 27% as intentional. And this has sat somewhat stable over time. So intentional deaths, they've accounted for around 22 to 31% of drug overdose deaths over the years. What is notable, though, is the increase in the rate of unintentional drug overdose deaths over the years. So they've nearly doubled. They've increased by around 4.1% on average per year, peaking in 2018. By contrast, if you look at that second line, the rate of intentional drug overdose deaths, it's remained relatively lower as compared to unintentional and relatively stable. Again, in saying this though, it's important to look beyond just the intent of death to understand the broader context and risk factors there. And it's important to note here too that these risk factors, while they're not routinely recorded on death certificates in Australia, we know that all of these psychosocial factors, things like employment, housing, social support, family support, they're really important determinants of health outcomes and mortality patterns as well. And full credit to the ABS. So the ABS has just gone through a process for deaths from 2017 onwards, where they've gone through all the coronial records, the police, the pathology reports of coroner certified deaths, and they've gone through and coded a range of psychosocial risk factors for deaths to acknowledge the importance of these factors, and so that we can gain a greater understanding of the circumstances beyond the death itself for the person that might contribute to their experience. Now, it's great to have these numbers. I do want to note here that I would take these numbers as likely a heavy underestimate of these factors. So it's only what can be extracted from those reports around death, from those coronial reports, the police report, the pathology report. So this is the bare minimum in terms of what can be identified from those reports. But what it does tell us, though, is that at an absolute minimum, just over 1 in 10 deaths that occurred in 2021 had a personal history of self-harm identified across those reports. Other frequently identified psychosocial risk factors that we see disruption of family by separation and divorce. We see limitations of activities due to disability, and other impacts around disappearance and death of family members as well. We've done some breakdown of these risk factors by different characteristics, and what's really stark that's stuck out to me from these findings is when you look by sex, there's a real divergence there. So for females, looking at that personal history of self-harm, for both males and females, personal history of self-harm is the #1 most commonly identified risk factor. But there's a difference in the percentage. So for females, it was 17% of female deaths in 2021 where there was a personal history of self-harm recorded, versus 8% for males. And similarly, when we look across age, the percentage of risk factors was much higher for adults 65 plus than younger adults. So there are demographic differences in the experience of these risk factors as well. I just want to note 2 other important contextual factors when thinking about risk too. So these are 2 things that we often talk about, but the first one being most of these deaths, 3 and 4, they occurred at home, and this has been consistent over the period of monitoring. I've mentioned this because it's really important for us in terms of thinking about how we can stop an overdose becoming a fatal overdose, and whether there may be others at home present who can intervene. It's also rare that we see these deaths involve one drug class. In 3 and 4 cases, we see them involve multiple drug classes, and actually 30% of the deaths in 2021 involve 4 or more drug classes. So this is all important information when thinking about preventing risk of overdose and fatal outcome. Finally, looking to see what's happening in terms of the drugs involved. So when we talk specifically about what drugs involved, you can see that in 2021, opioids were the primary drug class identified in nearly 3 in 5 cases. This is followed by anti-epileptic, sedative, hypnotic, and anti-Parkinsonism drugs, which is a lot of words to say. But when we look into that, really predominantly comprises benzodiazepines, which are involved in 45% of deaths. It's followed by antidepressants, amphetamine-type stimulants, antipsychotics, and neuroleptics, and finally, alcohol involvement. Looking at the rates over time, what you can see up until 2019, when we have that finalised data, is that for the most part, for most drug classes, rates have increased over time across the drug classes, typically peaking around 2017, 2018. And we see particular increases for classes such as antipsychotics and neuroleptics, and also amphetamine-type stimulants. It's really important to note with this too, that we do need some caution in terms of looking at these trends over time. There can be multiple drugs involved in these deaths, but also there's changes over time in what drugs are routinely screened in deaths. So that may factor into some of the trends over time that we're seeing. Focusing to look on opioid deaths. So as mentioned, the typical peak in deaths that we saw around 2017 or 2018, that really holds true for opioids as well. We saw opioids deaths peak in 2017 and then subsequently decline, but there has been a shift in the types of opioids underlying these trends. So in 2021, we saw that most opioid overdose deaths involved opioids like natural and semi-synthetic opioids, things like morphine, oxycodone, and codeine. 1 in 3 involved heroin, 1 in 5 involved methadone, and nearly 1 in 5 involved synthetic opioids like fentanyl and tramadol. What is interesting though is that if you look at the figure showing rates, you can see that natural and semi-synthetic opioids like morphine in the purple have been most commonly identified over time. But really what we can see is that they started to trail off from around 2017. However, deaths involving heroin have increased from around 2014 and actually overtook the rate just slightly for natural and semi-synthetic opioids like morphine in 2020. While the numbers are starting to look like a bit of a decline there in the 2021 for heroin there in the orange, the data, as I mentioned, are subject to change and will likely only increase. Moving to look at stimulants, we've seen amphetamine type stimulants and cocaine or deaths involving these increasing over the years. So amphetamine type stimulant deaths, so that's things like predominantly methamphetamine, but also MDMA, they've risen by on average 14% per year, peaking in 2020. While the estimate for 2021 is lower, again, I anticipate that this will increase. Similarly for cocaine, while lower numbers, we have seen the rate of deaths involving cocaine increase over time. So around by 12% on average per year up until 2019. And finally, I just want to show this quick finding around the demographics for opioid, amphetamine type stimulants and cocaine deaths, because I want to really reinforce again that importance around studying the characteristics underpinning these deaths. So as you can see here, when we look by sex, you can see that the percentage of males underlying these deaths increases as we go from opioids through to cocaine. And what also is interesting is that we've seen, you can see that opioid and amphetamine type stimulants, it's a slightly older age profile as compared to cocaine. And for both opioid and amphetamine type stimulants, we've seen a shift over the years to an older age group experiencing these deaths. So to wrap up very quickly, as a summary, we can see that around 5 Australians per day die from drug overdose and other drug-induced causes. When we look to see what the typical profile of these deaths look like, they are typically unintentional, occurring among males, occurring among those aged 35 to 54, among residents of major cities, in the most disadvantaged areas, occurring at home, involving opioids, involving multiple drugs, and linked with a personal history of self-harm. I want to acknowledge that we're talking broader than opioids here, but I find this image from the EMCDDA really useful in thinking about how we talk about preventing opioid overdose and overdose more broadly in terms of different levels of strategies. And I think the findings that we've presented here really help us hone in on some of those strategies. So like I said before, around 3 in 4 deaths occur in the home. This really enforces to us when we're looking at that stage around trying to reduce the risk of fatal outcome from overdose, that things such as take-home naloxone are really important. And I don't want to miss the opportunity to talk about the national take-home naloxone program that the Australian government is offering, where naloxone can be accessed for free over the counter by anyone at risk of experiencing or witnessing overdose in Australia. But similarly, that finding around multiple drug involvement, that really speaks to the importance of education and overdose awareness to try and make people aware of the risks associated with multiple drug consumption to try and reduce that risk of overdose. But it's that final stage, that reducing vulnerability, that I want to talk about a little bit more and go for the bigger picture, because while I focused on drug overdose deaths here, we know that people who are regularly using or dependent on certain drugs have a greater risk of mortality more broadly. Indeed, we've done some recent systematic reviews, and it showed that relative to their age peers in the general population, people who use opioids extramedically, they're at 10 times increased risk of mortality relative to their peers. So there's really quickly, and I know I'm running over time, really quickly 3 key things that I want to take home that I've pulled out. I think from these findings that we really, really need to focus in on the social determinants of health. These data just reinforce how important they are with respect to mortality. The greater proportion of people who are living in low socioeconomic areas, those psychosocial risk factors I talked about, unemployment, legal problems, housing problems, they are all risk factors identified as occurring in the lives of people we've studied. Interventions like naloxone, they are critical. Interventions like opioid agonist therapy, also critical. But we also need to acknowledge that broader social and structural determinants of mortality and health and think about how they can be addressed in our response. My second point that I want to touch on briefly is acknowledging the role of suicide and self-harm that we see in these deaths. 1 in 4 were intentional, and at a minimum 1 in 10 had a history of self-harm. And we know that from looking at hospitalizations, the rate of intentional poisoning in hospitalizations is higher than unintentional poisoning. And my take home here is that we really need to think about the role of suicide prevention in overdose as well. And my final point, which is intertwined with the previous two, is around this aging cohort. What we can see here is an older group of people who are dying from drug-induced causes in Australia. And that reflects a trend that we're seeing more broadly in terms of our population of people who are using drugs. There are likely to be unique needs for this population. We know that there's accelerated aging from chronic substance use, that this older cohort are likely experiencing significant physical and mental health comorbidities, and there are psychosocial challenges as well. And this group have particular needs that we need to consider into the future. So if you'd like to find out more, check out our report. I didn't cover all the findings by jurisdiction, but there are jurisdictional summaries available. There's an interactive visualization you can use. I'd like to acknowledge our partners in this work, and I'd like to acknowledge our funders, the ABS, AHW, Australian Coordinating Registry, and all the people who did so much work to make this report come to life. Thank you.
Thank you so much, Amy. That was such a great presentation and some really insightful findings. It just really highlights the importance of acknowledging and understanding these deaths, so we can, especially around the characteristics, so we can really work to try and prevent similar deaths happening. And, you know, it's really important to acknowledge that these stats are really good, but there's also individual families and loved ones that are impacted by this every day. I would now invite the panel members to turn their camera on. So Lauren, Paul and Melanie, if you can turn your cameras on, that would be great. We have had lots of questions pop in. I was going to hand over to panel members to provide their thoughts and reflections on it, but I don't think we're going to have time. So we'll jump straight into questions. Thanks everyone for sending them through, and please keep sending them through. We've got just over 15 minutes, so plenty of time. The first question is actually a really good one. It's a question I have also asked Amy, but it is around how this report is different to the overdose report that Pennington Institute released.
Thanks for the question. Yeah, so there are a number of different agencies in Australia who report on overdose and other drug-induced deaths. And we all have come at it from a different angle, I would say. So the work that we do is funded by the Australian Government Department of Health as part of this broader drug trends program of work, where we monitor different sources. With our piece of work, we have been publishing it for over 2 decades. We work quite closely with ABS and AHW on this reporting, and we undertake quite extensive analysis of the data, including formal statistical analysis of the data. So I think it's a reflection of a really strong field in that we have the opportunity to have different people reporting on these numbers and promoting and reinforcing the importance of knowing what's happening with these trends and having at the forefront of our minds how to respond to them. Lauren, is there anything you would add to that?
Yeah, I know Karen is online from the Pennington Institute, so hopefully I represent it correctly, Karen. But I think it is all about complementary figures as well. So the Pennington Institute also does quite a lot of work around unintentional overdose. They look at alcohol and provide a lot of commentary around really low-level geography for local areas, which helps to really fill in some of the gaps with that space and complement the information that NDARC also puts out there.
Thanks, Lauren and Amy. Our next question is, I might throw this up to anyone, so I think this sits across all 4 of your expertise, but would love to hear thoughts on whether some of these risk factors could be impacted by situations like medicine hoarding and availability at home. Melanie or Paul, I think I'll throw to you to give you some stage time.
Well, I guess, I mean, we had a wonderful natural experiment with the pandemic, and that several jurisdictions relaxed their regulations around take-home doses of of replacement pharmacotherapies like methadone and Suboxone. And this happened in several international jurisdictions as well. And everyone was a bit surprised that there was no significant change in harm attributable to those medicines in the jurisdictions that relapsed there. So that's an example of, people having access to larger amounts of an opioid, quite a strong, potent opioid, without seeing an increase in mortality. I'm not sure if that's what the question's about.
Yeah, look, I'd build on what Paul's saying there. I think we did see demonstrated during the pandemic exactly what Paul's saying. There was a lot of concern from some sectors around making more take homes available for people during lockdown periods, and that didn't equate to a greater number of overdoses. Just in terms of the very recently announced decision around prescriptions for medicines for people with chronic conditions, and that going from the 30 days currently to 60 days, I think 30-day supply of drugs is well enough for somebody to be able to do themselves harm. I'm not sure that it's going to make a great deal of difference if we go to 60 days. Yeah. So I think that might answer the question in two different ways.
Thanks, Melanie and Paul. Your views were really appreciated. Sorry, they keep coming in, which is great. It means I have to keep scrolling to the top again. The next question is around deaths involving cannabinoids. So there seems to be a spike in deaths involving cannabinoid, which presumably comprises cannabis and synthetic cannabinoids. Do we know if that's related to a wave of toxic synthetic cannabinoids or if it's related to anything else?
I'm happy to jump in here. So I think adding to some of the caveats and cautions that come with the drug-induced death data set, as we're coding and compiling the national mortality data set, I think every component is up for improvement over time. So some of that is actually at an admin effect where we're getting more reports. We're really lucky to have access to the National Coronial Information System, who also works with stakeholders to ensure that we get reports passed on to us. From a coding perspective, what we're really trying to focus on now is making sure that we separate when cannabis is just present in a death as opposed to when it's actually involved in a drug overdose. So what we find is it's very, very rare for cannabis to cause a death as the only drug, and anecdotally when it does tend to be synthetic opioids, but that spike is nearly all in multiple drug overdoses, and there would be a component of those where cannabis is just present as opposed to really contributing to that pharmacological effect. So we'll have more on that over time as we keep coding and producing data as well, and hopefully give good guidance there.
Thanks, Lauren. I'm going to combine two questions here just because there's so many coming through, which is great. But the next question, so could the decline in natural semi-synthetic opioid deaths be due to regulatory change? And I guess extending that even further, which I think it would be too early to tell, but is there any participated changes in the spike of deaths after the take-home naloxone program was rolled out more broadly? I mean, noting that was only a national rollout was 1st of July last year, but there was that 2-year pilot.
I could speak to the first part of that, I think. But can you just, I'm just looking how it was worded. Look, I'll give you a mental image. I want you to imagine I'm holding a balloon, and the balloon is Australia's drug policy, and the air that inflates the balloon is the demand for drugs. And when we try to regulate supply of drugs more strictly, or when we try to block the supply of illicit drugs, what we're doing is trying to make the balloon smaller without letting any air out. And it's a magical balloon, it doesn't break, it just bulges out somewhere else. And Amy already pointed out the trend from about 2014, the proportion of deaths that are related to pharmaceutical opioids declining quite dramatically. And over the same 5 or 6 years, the proportion of deaths that are related to heroin doubling or more than doubling. So, what we're seeing is displacement, not, so regulating those pharmaceutical opioids, I think, has displaced more people towards heroin. We've seen something similar with some of the deaths related to benzodiazepines and related to sedative drugs and some other, pregabalin, some of these other drugs. As we've controlled the benzodiazepines more strictly, we've started to see counterfeit Xanax emerging in the last few years. We've started to see novel benzodiazepines which aren't prescribed in Australia appearing in some of these deaths. We've seen an increasing proportion of these deaths involving drugs like Seroquel or pregabalin. And I think we're looking at the same sort of dynamic there, where we've started strictly controlling something there was a demand for, but we haven't done much effective about the demand. And so it gets displaced to the next least worst alternative substance. Yeah.
Thank you, Paul. Did anyone have anything else further to add to that before I move on? Okay, great. A really good question here around the measurements of unintentional and intentional deaths determined. So Amy, I'm thinking you might be best placed, or Lauren, to answer that one.
Lauren, do you want to?
Yeah, sure. So it's definitely one of the more difficult components of coding is determining the intent. For closed cases, we would always take the intent that the coroner has put on the coronial finding. For open cases, it is a little bit trickier, and hence why we have the revisions process as well. But we would look for elements in the police narrative and the autopsy narrative. So it could be presence of a suicide note and things like that. So if those things were present, intentional self-harm would be assigned to the case. When we're doing the revisions process, there's often updates to the intent for drug-induced death. So something may move from accident to suicide, but it also can move the other way. Something could present as a suspected suicide and then be found to be unintentional. But we have the group of undetermined intent to capture ones that in the meantime can't be decided.
Thanks, Lauren, for that clarity. Melanie, I might ask you a question, which is a really good point. So given the prominent socio-economic status contribution to a lot of these deaths, do you anticipate that we can expect to see an increase in 2023 and beyond, given the increased cost of living and the stress that everyone is under financially?
I'm really glad you gave me that one because I was just looking at it. Obviously, it's not a straight line, but researchers will probably be appalled at how I'm going to oversimplify this, but things that make people sad and stressed increase the risk of overdose, both intentional and unintentional, through a range of risk factors. And so I think if you want a yes/no answer, I think the question's yes. It's certainly not going to help. Anything that increases stress and pressure on people is not going to be good in terms of risk factors for overdose. And I think that's what's really strong. And looking in the comments as well, it's really great to see this increased focus this year in the data and report on social determinants of health. And I think what I've said just there, things that make people sad and stressed are bad. The other thing that jumped out at me in the social determinants was around prison release. And I think that leads as well to building our case around availability of naloxone. What would be really great if there were some more targeted programs, naloxone for people leaving custodial settings, for instance, naloxone for first responders. Some of these things we can address as well. But in terms of increased financial pressures of living, it's not going to be a good thing, obviously.
And just, I see that Robert Kemp has commented in the quick Q&A, term deaths of despair. And if you Google deaths of despair in inverted commas, you'll find a bit of American literature around this trend of increasing deliberate overdoses and so on.
Thanks, Melanie and Paul. We probably only have time for one more question. And I think this is an important one, noting that because of the way the data is coded, that it's often talking about drug classes rather than specific drug types. So like opioids, do you think, Amy and Lauren, is there more detailed data available on other drug classes like antidepressants and anti-epileptics?
Yeah, so maybe I'll kick off with that one. So as you can tell, the report is already quite long, but if you want to head to our data visualization, we provide a lot of additional breakdowns in the data visualization. So that does include breakdown by drug type, and we go down into some more specifics around the drugs. So broader than those, more specific than those broader categories I showed you. And you can do breakdowns by intent, sex, age, and where possible by remoteness and by jurisdiction as well. I think that's where the National Coronial Information System and having access to that database and being able to report really gives us a lot more nuanced data as well. So we can, when we go directly to the National Coronial Information System, search by a specific substance. And that has allowed us to do studies on specific drugs as well. Maybe, Lauren, I can throw to you too around ICD-11 and whether that may offer any opportunities.
Yeah, so at the moment we are coding to ICD-10 and there's definitely known limitations with the coding groups there, but we are working very hard to move to ICD-11. So hopefully in the next few years for mortality, we would move there. The drug classification there is based on the international non-proprietary names, so it has a very, very detailed list. So even things such as natural opioids, we could break down by codeine, morphine, etc., and look at those individually. So that's definitely where we're heading as the ABS with the classification, and that will open up a lot more opportunity for research in future as well, and hopefully give more inputs into policy.
Thanks, Amy and Lauren. Wow, I don't know about everyone else, but it's information overload and a lot of food for thought. So I'd like to thank everyone for joining today and for making the time to hear more about this really important topic. The questions asked were awesome. They were very well considered and raised some really interesting points. Massive thanks to Amy for the wonderful presentation and all the work that went into this report and the Drug Trends team. Also special thanks to Lauren, Melanie and Paul for their insightful thoughts and views and for being so open to answering all the questions. And Melanie and Paul, I'm glad I didn't have to cut you off because you were speaking too much. So thank you for not making me look like the bad guy. Before I finish up, I just want to do a plug for the upcoming webinars that NDAC are doing. So next week on Thursday, 11th of May, there will be a webinar by Olivia Price on the vaccine uptake among people who inject drugs, the pandemic and beyond. The week after, on the 18th of May, Professor Leanne Hines from the University of Queensland will be presenting on using technology to implement client-reported core outcome measures with feedback into alcohol and other drug treatment services. And the following week, on the 25th of May, Dr. Nicholas Taylor from the National Drug Research Institute at Curtin University will be presenting a webinar on the minimum unit price of alcohol in the Northern Territory. And while we're here, I'd just like to remind people that the save date has gone out for NDAC's annual research symposium, which was being held on Thursday, the 27th of October. That will be held at the John Nyland Scienter building at the University of New South Wales in Sydney, but will also be live streamed for those that are unable to make it in person. So thank you very much, everyone. Thank you for making the time. Thanks to the team for all the hard work and for joining us here today, and enjoy the rest of the day. Thanks, everyone.